Good morning, everyone. I'm really delighted today that our very own Australian Professor Julie Heights has come to join us all the way from Brisbane. And I'd like to say a very sincere thank you to Julie for coming along to talk to us. Julie is certainly one of Australia's leading experts, if not Australia's leading expert in musculoskeletal health in space. So I think we're very privileged to have Julie with us today. I'll just read Julie's bio and then hand over to her. Julie's a Professor of Physiotherapy at Griffith University in Brisbane, and she's a titled Musculoskeletal Physiotherapist, a Fellow of the Australian College of Physiotherapists, and the Clinical Director of the Back Stability Research Clinic located at the Mater Hospital in Brisbane. Julie has been a collaborative scientist on several international multidisciplinary analogue advisory groups, Topical Teams, and astronaut studies with the European Space Agency. The most recent Topical Team focused on rehabilitation of astronauts post-space flight. Julie is currently a co-researcher on international scientific projects being conducted by the European and U.K. space agencies. This research experience has led to opportunities in Australia, including being a member of the Australian Academy of Science National Committee on Space Medicine and Life Sciences Working Group. The resultant report, Australia in Space, presents a 10-year plan for Australian space science. Julie was also a member of the Space Medicine and Life Sciences Technical Advisory Group for the Australian Space Agency. The resultant output is a roadmap document entitled Applied Space Medicine and Life Sciences, and this roadmap will be released in the latter half of 2022. So thank you again, Julie, for coming along today, and over to you. Looking forward to hearing your talk. Thank you.
Thanks, Rowena, and my pleasure. So I'll just share my screen and hopefully that will work for us. So you've got that, great. So I'm going to have a little chat to you today about a little bit of a funny title. We've got what do astronauts, back pain patients and elite athletes have in common? And the reason I've called it that is to really try and emphasize that it's space research is wonderful, which is why you're all with Rowena, which is and it sounds like an amazing program. But obviously we have to have some applications of our work on Earth for it to be really worthwhile. So I'd like to take you through a series of studies that we've done, and I'd like to, at the end, I will bring it back to Earth-based science around back pain and around athletes, just so that you can see how we try and apply the work that we do. And as Rowena mentioned, I'm a physiotherapist, so it's going to be heavily biased towards muscles today, as well as exercise. And usually when I give a talk of this nature, I usually start with back pain and muscles, and that's where my research started quite a long time ago. And then I end up with the space stuff as a really sort of, this is a really interesting application of this work. So I flipped it today so we can talk about space research first, which is your area of interest, and then I'll try and at the end we'll make sure that we try and apply it and show translation. And of course, for research at the moment, any funding that you go for is really linked to impact. You have to justify what is the impact of your work, and I'll try and give you an impact case study to give you an example of that. All right, so here's a little bit of an overview. We're going to start talking with some analogue studies. I'll give you the results of some of the bed rest studies that we've done, some parabolic flight studies. I will talk you through some of the astronaut research, and that's been a real privilege to be involved in. And then, as I said, I'll try and wrap it up with some back pain and sports research to give you an idea of that sort of impact. And then we're going to talk a little bit about the common thread that runs through that research, which is really the function of muscles, how we identify impairments, then how we try and intervene, a bit of an example of how we use imaging in all of those aspects. And some of these studies are cross-sectional, some are longitudinal and some are interventional. So I'm giving you a little bit of a range of different types of research approaches that we've used. So there's been an interest in intrinsic muscles in microgravity for quite some time. And if you look at that picture in the middle, you can really see that when you're in space, it's a bit like the most common thing you could think of on Earth is like when you're swimming underwater. So it's probably not unexpected that you use a completely different muscle set in microgravity that you do when we're here on Earth. And if you think of swimming along underwater and using your arms and your pecs in a flexed position, that's very much like what the astronauts are using when they're up on the International Space Station. And originally, a lot of the work was conducted on the leg, on the quadriceps and the hamstrings, because it was easier to study than the spine, which is obviously quite involved. So, but people did notice very early on that in space, you lose your intrinsic muscles of your spine and you lose them quickly. So that probably led to a real interest, not just in the leg and the limbs, but in looking at the spine and the spinal muscles in our analog studies, which the main two we're going to talk about today are prolonged bed rest and parabolic flight. And we're going to start with the prolonged bed rest. So I've been involved in a few of these now, and they are fascinating studies to be involved in. And that picture is, you can see the bed that the subjects are positioned in. They're usually 6 degrees, head down tilt for 56 to 60 days. And of course, they don't get up at all during that period. And there's different studies looking on every bodily system, as well as there's studies looking at interventions during bed rest. And then there's studies looking at people after bed rest. So there's various time points and various interventions that have been trialed. But of course, it's not the same as microgravity, because even though we've removed axial loading, we still obviously can't move around like we can in space. So it's not quite the same, but it's a commonly used analog. So the Berlin bed rest were a series of bed rest studies that were probably the first ones that I was involved in. And really, when in this study, when we looked at the back muscles, so the muscles we were really interested in, you can see here I don't know if you can see my little pointer there, obviously the vertebral body, psoas at the trunk, multifidus, lumbar rectus spinae. The multifidus, or one of the intrinsic muscles of the back, is really of interest to us for back pain research, which I'll highlight to you a little bit later on. And this is an MRI of a person at the start of bed rest. And then this is an MRI at the end of bed rest. So when we first observed these changes, we really thought it's very much like letting the air out of the tires. And we wanted to map how quickly these changes occurred. And I suppose it's a little bit intuitive. You'd think if you went to bed, all your muscles would atrophy because you're not really using them. And in space, we see this as well. You have some muscles that love space and some muscles that atrophy. So we get this very differential response in different muscles. And this is on the y-axis, we've got the percentage, this is 0, percentage increase in muscles or percentage decrease in muscles. Across the x-axis is time. So the start of bed rest, BR is bed rest, 14 days, 28 days, 42 days, 56 days. And these are different muscles and different colors. So the multifidus, that deep intrinsic muscle, atrophies within 2 weeks. And then it's probably the muscle that atrophies the most by the end of bed rest. The lumbar rectus spinae atrophies as well. QL stays pretty much the same or gets slightly bigger. The abdominal muscles get bigger. The psoas at the trunk gets bigger and rectus abdominis gets bigger. So this was quite a unique finding. We thought, well, this is really a nice representation of a muscle imbalance. And you get almost this same pattern in the astronauts. So they have muscles that atrophy quickly and other muscles that actually can hypertrophy in space. So you would think then, all right, well, if some of these muscles, once you remove the stimulus of axial loading, I would probably think of them as anti-gravity muscles, you'd imagine that they would come back by themselves once you go back to normal activity. So same as we were looking at earlier, this is just for the multifidus. So bed rest through on the x-axis to R+4 is recovery, or when they get up from bed. And we looked at this muscle and mapped it, and at 90 days, it hadn't come back, which was despite resumption of normal work, sport and leisure activities. So this is quite an interesting finding. We have these muscles that can be turned off by different stimuli, and then you think, oh, well, you just resume your normal activities, they'll come back, but they don't necessarily come back. And this is something that we see in our clinical studies as well. So this was probably helpful for us, actually, because in this first study, they didn't really get rehabilitation or reconditioning post-bed rest. And so it was a good argument in our funding grant applications to say, well, you know, if they're having these muscles haven't returned 90 days later, we should be giving these patients, participants, some kind of reconditioning. So this is the most recent bed rest I've been involved in. So Agbrisia, so artificial gravity bed rest with ESA. And this was in Cologne. And I'd like to give you some of the results. It was artificial gravity was obviously the intervention that they used during the bed rest period. And this is Enrico De Martino, who's an Italian doctor that worked on a lot of these studies. They were led by Professor Nick Kaplan from Northumbria Uni. And this is actually where they delivered the artificial gravity. So the participants were wheeled on their beds, kept at their head down, 6 degrees head down tilt, slid across onto the centrifuge, where they actually were experiencing 30 minutes daily of artificial gravity. And that's one of the participants. So one group had this broken up into 5 or 6 minute intervals. The other group just had 30 minutes daily. And so the purpose of this was to see if this intervention, because the centrifugal force provides an axial loading through the body, could it actually stop the atrophy of the muscles during the bed rest period? And we looked at the size of the muscles. Here's the MRIs of the lumbar spine, and looked at the discs and the lordosis. And we also looked at fatty infiltration of the muscles. So I'll tell you a little bit later a bit more about that and how it applies to studies with humans. But we knew that the atrophy occurred quickly in bed rest, but interestingly, the fatty infiltration occurred as well. So this is pretty quick. You think, you know, you're a normal, healthy person, you get put into bed. It's not just that the muscles you're not using decrease in size, but they start changing their consistency or their structure. And it doesn't just happen everywhere. This is like a heat map of where you're seeing greater fatty infiltration changes. And in the multifidus, for example, you can see that it happens close to the bone. And same for inside and outside of multifidus. It's deep ventromedial corner next to the zygapophyseal joints. There's often an area in back pain where we see these changes. So they happen quickly, and the muscles don't like it if you remove their normal role, which is control of the lordosis. They're an anti-gravity muscle. They have a segmental innervation. And when you're upright, they're buzzing along and just controlling the movement of one vertebra on the next. So bed rest or space affects them pretty dramatically. And this is Vienna Tran. I put this in just for interest for you. Vienna did medicine and did her honours at University of Adelaide with Gordon Cable. And I ran into Vienna at a conference. She said, is there any chance that I could actually work on one of the studies when I do my honours? Yeah. And she studied the effects of bed rest from the same series of studies. And she looked at the gluteal muscles. So gluteus maximus, gluteus medius, and gluteus minimus. And interestingly, the artificial gravity did not mitigate the changes on the hip muscles either, which we decided pretty much made sense, because if you were trying to hypertrophy your gluteal muscles, the equivalent of being on the centrifuge for 30 minutes a day would be the equivalent of standing for 30 minutes. And I don't think you would think on earth that would hypertrophy your gluteal muscles, which work when you run, when you go uphill, when you come into inner range hip extension. So this is one of the participants from the bed rest study. And apart from muscle atrophy and those fatty infiltration changes that we were talking about, the lordosis changes dramatically. And this is also seen in the astronauts. And it's because you don't have axial loading anymore and you become quite flexed and your discs can imbibe more fluid. There's not that usual diurnal change. And we certainly saw the bed rest participants that once they came out of bed, their backs were completely flattened. And this was a study with this lady here is Gunda Lambrecht. She's the physiotherapist from ESA who looks after the astronauts. And I was very fortunate to work with Gunda. We did the rehab after the Berlin bed rest study together. And you can see that Gunda here is working to try and teach this person to actually re-educate that lumbar curve. Because if you think on earth of weightlifters or how pedantic they are about having their spine in the right position when they add load, it makes complete sense that we shouldn't really be exercising these people until we've actually helped them to regain a normal cervical lordosis, thoracic kyphosis, and lumbar lordosis. And we certainly could rehabilitate the muscles following bed rest. So I'm just going to give you another example of an analogue study. And this again was with Nick Kaplan's group, which was a parabolic flight. So parabolic flight, so the vomit comet, I'm sure you're aware of them from your studies. It gave us a great opportunity to look at the effects of microgravity on the paraspinal muscles. And of course, it's quite quick. So again, Enrico he's got fine wire electrodes in this participant, as well as Vicon, so movement sensors. So we could look at the spine, the position of the spine, as well as what happened to the muscles in a very brief period of microgravity, which is achieved by the parabolic flight. And basically it was a response to a perturbation. So those little sensors pushed the person and we looked at the response of the muscles. And without you having to go into too much detail about this, the multifidus muscle, the iliocostalis at the lumbar spine, the response to perturbation changed even in that brief period of microgravity. So the take-home message is that we know microgravity, bed rest, that they affect the intrinsic muscles. What the parabolic flights add is that it's incredibly quick, that over a period of 60 seconds, your body will respond differently to a perturbation than it would on Earth. This is the parabolic flight. I don't know if you've seen these before, but I thought I'd just show you what this looked like. So you could see that the investigators in the study quite enjoying the parabolic flight experience. So now let's have a little bit of a chat about some of the astronaut studies. So here's Gunda, the physio that you met before on the bed rest studies. I think for astronauts, we use the term reconditioning rather than rehabilitation, and that's because they like to be seen as normal, fit, healthy people who go into space or into a different environment and then come back and have to recondition their muscles rather than being patients per se. So the main intervention that's been used on the International Space Station is the ARED, the Advanced Resisted Exercise Device. The difficulty with exercising on the ISS in an apparatus like this is that your proprioception doesn't work well in space. So your muscle spindles, obviously your vestibular system is affected. And we want to add quite high load to try and mitigate the changes in bone and muscle that occur while you're in microgravity. So we run the risk of, if we actually have people adding high load, and you can see this is all done via hydraulics because it doesn't work obviously to lift weights in space. So they have this resistance, they have quite high load, quite high axial loading, or they can do this in different positions. It's quite a flexible device. But if they load in a poor position, as I mentioned before, your elite weightlifters are pedantic about their spinal position, because if they come out of their lordosis, they're much more vulnerable to injury. So Gunda's sitting here at Cologne at EAC, and European Astronaut Centre, there's a direct video link to the ISS, and she's watching the astronauts exercise. And so she can give them verbal feedback because they're not getting their own feedback. You know, your chin's poked forward, or your bottom's tucked under, you need to maintain your curve, you need to pull your chin in. So they're actually given feedback whilst they're doing the exercises, which of course will be a problem for long duration missions, in that if we try to go to Mars, you can't fit the ARED on the ship for a start. And secondly, there won't be a live video link. There'll be up to a 20-minute delay. So this is how it's worked on the International Space Station. And we've looked at, they get taught the exercises. This is NASA on Earth, and a lot of attention paid to how to do this kind of exercise, but yet it's still very difficult because they don't have their normal biofeedback working. Of course, they also can do their cardiovascular rehab, so running on the treadmill with the bungee cords. And as I mentioned, they can use this ARED device. So here it is being used for like pecs and arm muscles, as well as obviously what we want, axial loading to maintain the bones of the spine and the intrinsic muscles. So we've looked at 6 astronauts from the ISS to see if it actually did mitigate the loss in muscles. And basically we're looking here at cross-sectional area of muscles again at different vertebral levels. This is L2, L3, L4, and L5. The red is their pre-flight muscle cross-sectional area. And then we're looking at R+1, so when they first get back, R+8 and R+15, so 15 days after return to Earth. And it was quite interesting to see that there's different changes at different vertebral levels. So the greatest loss is at L5 at the lumbosacral junction, and that's where this muscle is the biggest, but also where it has the greatest need to control the position of L5 on the sacrum. Up at L2, the ARED completely maintained the size of the muscle. So this is quite interesting. It's different for different vertebral levels. The good news, though, is for this L5 level, by R15, and this is daily intensive reconditioning that they have at ESA, the multifidus size had been recovered. So this might be a little bit different from what we see on Earth, because a lot of back pain patients who have atrophy of their muscles might take longer than 2 weeks to actually recover them. But what it provides us with is an amazing opportunity for a model to actually study muscle atrophy and response to rehabilitation, because we don't have pain in the mix. We don't have all these other things that affect reconditioning. We have normal, healthy individuals. We have a predictable change, and then you can try different things to see if it actually helps to recover the muscles. This is actually, I've worked with NASA, and we've tried to actually, so that study I just showed you, we had imaging before and after space. We've tried to actually do the imaging in space as a protocol, and we're moving forward with this. There are a few challenges though. On Earth, obviously, you just lie someone down on the bed and image them. In space, they've got to be tied down so they don't float around. And another astronaut was obviously trained to image another astronaut on the ISS, and this work is in progress with Rick Schuring. And I like this. Questacon actually did a traveling exhibition in Australia in space, and they asked NASA if they could put this picture of this astronaut being imaged on the ISS in their display. All right, so how does this relate to Earth? Let's come back to Earth and we'll have a bit of a chat. Just check how you're going for time. A bit of a chat about back pain. And as I mentioned earlier, it's super important for us that there are we can draw these parallels between bed rest, microgravity research and exercise or conditions on Earth, which could be back pain, could be osteoporosis, could be osteoarthritis, could be intensive care rehab. So we've written papers on what are the possible applications of space research to musculoskeletal research back on Earth. The intensive care ones, actually, that's not my area, but they're really interesting. They're thinking patients like your Guillain-Barré patients. And of course, there's a huge field of research opening up to everyone, which of course is COVID research. I've got a PhD student working on long COVID at the moment, and what a multi-system disease. And I mean, it'll be everyone will be working to try and help people that have been affected by COVID. And of course, there's lots of them. So we think bed rest, microgravity, these parallels to the neuromuscular system, they're important for us so that we can actually understand, improve and tailor our interventions. And this is actually an AFL player running through a series of exercises using TheraBand. And of course, TheraBand was invented for space. And he's got it under his heels. So for any weight-bearing muscle exercises, we always consider the line of gravity and where it runs. So from behind your ear, middle of your shoulder, middle of your hip, middle of your knee, but just anterior to your lateral malleolus. So we'll try and replicate that line of gravity when we do our exercises. And as he stands up and lifts his arms up, he's actually generating a compressive load on the spine. So we do use the information that we learned from our space studies for our Earth-based studies. So when we think about exercises and what type, there's lots of things for us to consider. And the first studies I was involved in looking at the back muscles, which I mentioned is usually where I'd start a talk like this, was that we found that people who hurt their back for the first time, their multifidus muscle atrophied really quickly. So you could hurt your back and like the next day, this muscle would be just so decreased in size. And we didn't know the mechanism of that, but we thought, well, we need to look at what would happen if we got in and worked on that muscle. And so we did an exercise program targeting the atrophied muscle and looked at the follow-up. So with acute low back pain, it's thought to have a really good natural history in that up to 80-90% of people are better within 4 weeks. But the problem with it is the recurrence rate is staggeringly high. So within a year, you've got 75-85% of people having recurrences of equal magnitude or greater after they've had back pain. And we did show that early intervention could decrease the recurrence rate. So this was the first study that we had done on this muscle. And we've looked at a lot of trunk muscles and a lot of studies. This muscle just seems to atrophy quickly. It seems to be like a marker. It very often is affected. And lots of studies now have confirmed that in lots of different conditions. So that was a study of acute low back pain. But as further studies have looked at the muscles, it's been really interesting to notice, a bit like your bed rest studies, that different things happen to the muscles at different time periods. So in the acute period, you get atrophy of the muscle on imaging, but it still looks pretty normal. Then in this subacute phase, you start to see this adipose or fatty infiltration. And certainly in chronic low back pain, you have atrophy of the muscles, as well as a lot of fibrosis and fatty infiltration. So I think this is really important because it actually influences what kind of exercises we should do. And we had a meeting a few years ago of lots of different experts from lots of different fields to try and talk about exercise and back pain and really what is the way forward. And we think that in this really acute phase, the reason why you see that rapid atrophy is reflex inhibition. So a spinal cord mediated response where the muscles basically shut down and your body obviously thinks that that is quite kind of helpful, which it might be in the acute phase, but probably not a good long-term strategy. You also obviously have your nociceptor stimulation, pain, and all the other things that happen to people when they're in pain, which is why I was saying it was nice for us to have the astronauts to study muscles. So there's lots going on. This loss of slow fibers in the multifidus can be quite problematic. You see a transition from slow twitch to fast twitch fibers. And for that deep muscle, it's meant to have a tonic activation. It's meant to, the muscle's just meant to be buzzing along and telling your brain where your back is in space. But interestingly, we get this inflammatory response in the adipose tissue. And there's been animal studies done now where they've actually lesioned a disc, looked at the response, and it's thought that this inflammatory response in the adipose tissue is probably responsible for a lot of the fatty infiltration. And interestingly, in the animal studies, if you do more sort of general exercise in this stage, you can sometimes avoid that inflammatory response. So we might be able to consider whether we can actually avoid the fatty infiltration in humans as well. So to summarize that, we think in this acute phase, you have this muscle inhibition. you lose size of muscle, and probably at this stage, we'd be wanting to, as physios, use motor control training, and I'll tell you a little bit more about what that is, to try and overcome that inhibition. So if the body is shut down the muscle, we're trying to say, all right, how do we facilitate it? How do we get that muscle turned on again in a functional sense? Then we've got this pro-inflammatory cytokinophase. In the animal studies, they think that then your general exercise promotes this anti-inflammatory effect. So I don't know if this has been proven in humans yet, but in the little mice, they put them on treadmills, and then they can, of course, section their muscles and see what's happened to them. But there may be a call towards doing that, which is you resuming normal activity, trying to get people to not be fearful of movement. But it seems to be very valuable and very important, maybe to prevent some of these next stages where we really see this, chronic disuse, deconditioning, fiber atrophy, fibrosis, and fatty infiltration. Now, by the time you're at this stage, we really have true atrophy of muscle fibers, and you need to load muscles. You need to overload to induce hypertrophy. So it just means that these very different stages, we need to use different exercise approaches to achieve what we're trying to achieve. So early on, we might be trying to wake the muscle up and get them to use it in function. But by the time people are at this end stage, we need to safely load them, just like we load the astronauts with the ARAD, to actually stimulate and induce that hypertrophy of muscle. And maybe middle of the road, there should be lots of that general activity. There is some preliminary evidence that fatty infiltration is reversible. We know we can increase the size of muscles when there's been true atrophy. But now this study, and there's been some others since that, have shown that if you actually load the spine in people with chronic back pain and fatty infiltration and atrophy, focusing on good technique and maintaining the lordosis, we can actually reduce the fatty infiltration. So that's really, really promising. So I mentioned motor control training. We would kind of describe that as a very umbrella approach for exercise, but we're looking at motor, sensory, and central processes with the belief that how you load your spine is really important. So it could in fact contribute to you getting back pain, or it could contribute to you continuing to have back pain if you're loading your spine in a way that's really, and this can be really not good, and this can be different obviously for different people. And a lot of the exercise approach that we use for the astronauts, for our athletes, and for our back pain patients is a very functional form of retraining. So we'll usually try and cue into the patient's goals, what they want to be able to do, what they have to do, say at work, and then we'll try and add things in to try and re-educate them and load their muscles in a way that's not painful for them. And we do have this big focus on trying to keep a lumbar lordosis, thoracic kyphosis, and how people load is really very important. And how far we go, it depends on people's demands, of course. I think one of the key features is endurance. Often people can learn how to contract muscles, but then they might have a job that's really quite demanding, and they need adequate endurance as well as the ability to be able to recruit these muscles well to actually win. So at the end of this meeting of all the experts, we did write this paper, which was really interesting because in the exercise world, there's all these different, you should follow this approach or that approach. I think clinicians as well as students really struggle and think, oh, do I follow this or do I follow that? And a lot of people were brought together in the same room to say, well, hang on, what's in common with the different approaches that we use and what's different? And even though approaches have different names and different followers, and this was multidisciplinary as well, it was really nice because there is a lot of principles in common with all these different approaches. So maybe in exercise, we're sort of shooting ourselves in the foot, naming these things different things. And for students as well as patients, if we can bring it back to kind of principles that are in common, it might really help to sort out quite a tricky area. I'm going to give you the results of a study we did at the MARTA Back Stability Clinic. So that's, I still go to this clinic every second Friday. And we looked retrospectively at the patients that had attended the clinic. Now, it's a it is an exercise clinic, so it's slightly biased population. It's people probably who are here to exercise because they know they're coming for exercise. But we wanted to actually look at this body of patients, look who actually had a good response or a good outcome, and to see if we could identify any features from the start who would better respond or who would have a better outcome with exercise therapy. So this was done as a retrospective chart audit by an independent reviewer. One of the things that was important, and when we think ourselves of what patients we think will respond better, the type of pain is quite important. So obviously acute low back pain, we know it gets better quickly, but it recurs. Chronic continuous back pain, people that just have this ongoing pain that doesn't really vary. But then these two are quite interesting, chronic fluctuating and chronic recurrent. So chronic recurrent would probably be our favorite. Episodic low back pain. So let's say I just went to pick something up and my back went, but then in between they're completely pain-free. And then these poor people with chronic fluctuating low back pain, there's always some pain. It might go up and down, but they're never without pain. So I'll tell you about what we found with that. So this was just the initial assessment findings. The people that come to this clinic are usually pretty chronic low back pain. You can see that this is the Roland Morris disability score, the visual analog scale, duration of pain. This probably makes sense. You are actually more likely to improve if you had less disability, if you had less pain, and you had a lower duration of pain. You're more likely to respond, and that, of course, is quite intuitive. But then here are a whole lot of other factors that were identified from the assessment to see what actually related to whether they had good or not so good outcomes. And you did less well if you had a structural problem like a scoliosis. You did less well if you had back pain and hip pain, and that makes sense. You did better if you had chronic recurrent pain. You were likely to have a good outcome if your type of pain was chronic recurrent. And you were likely to respond to exercise if you couldn't contract your muscles well to start with. So that probably makes complete sense. And a lot of physiotherapy is based on that principle. We try to identify an impairment. So say you can't contract your muscles well, we'll say, let's try and teach you how to contract them and then integrate that into function. So that was a really nice example from a clinical population and relates very nicely across what we've talked about for the astronaut studies as well as the back pain studies. A little bit more, the work on sport and elite athletes has been more around the importance of the trunk, not just for low back pain, trunk muscles, not just for low back pain, but for lower limb injuries. And it was Cricket Australia who first started looking at that with us. And now a lot of AFL clubs, can we actually decrease hamstring injuries, adductor injuries, lower limb injuries, if we can control the trunk better? So this is Delani Mendes. That's one of my colleagues that I work with. And she did a PhD on AFL players as well as some bed rest participants. And we've done a series of these studies now on elite athletes. We know the problem is a high incidence of lower limb injuries. And we've tried to say, can we influence this through looking at modifiable intrinsic risk factors? And here it is again, that same muscle. If you had smaller multifidus muscles, then you are more likely to have lower limb injuries, and especially in sports like AFL that have so much running in them. And it's been shown in several studies now that a small multifidus, especially at the lumbosacral junction, is a risk factor for lower limb injuries. We've actually intervened to see if we can actually change muscle size and whether it relates to injuries, which in the AFL are measured as games missed. And there were, in fact, less games missed from injury if you could control your trunk muscles well, which probably makes sense. And we have looked at trying to translate this into clinical practice, not just in the back clinic, but in our research as well. Because as I mentioned to you earlier, any of our granting bodies now, they want to see what is the impact of your work. And I'll try and give you an example of an impact statement in a minute. This lady here was a individual pursuit, an Olympic champion from New Zealand who had back pain. And you might have seen her earlier. Her functional retraining actually involved her working on the wind trainer, so we could actually get her muscles working more efficiently while she was doing the actual task that she required. So this impacts case study is with the Brisbane Lions. So that's Peter Blanche, who's the medical director of the Lions. And so the first part for your impact case study, what's the context of the problem? They were having sporting injuries, players unavailable, the cost as well as the burden on the players, as well as there's quite good evidence now for sporting teams that your chance of success of winning a competition is directly related to how many athletes you can keep healthy and on the field. So the more injuries you have, the less chance of winning your competition. So the proposed solution, we did a screening program using the identified risk factors, and in fact we worked up a clinical cutoff for the size of the muscles. So we knew from quite a few years of collecting data that if your muscles were smaller than this size, you had this increased risk of injury. And this is the physio from the Lions, Clint. He's actually, we developed a program for the Lions looking at various different things. You'll see some of the elements we've already talked about, the TheraBand, the control of your curves while you add axial loading. So you can see it all tying back to what we talked about with the astronauts, and this is an application of those kind of practices on Earth. And this was the results of games missed due to injury for all the AFL clubs in the competition. We've identified all of those. Here are the Lions. And the medical director of the Lions sent this to us. And now it's obviously not just our program, there's a lot of other things going on to keep athletes healthy. But since they instigated the program, they were having the lowest number of injuries of any of the AFL teams, and that was across 2017 to 2020. So that's an example of an impact case study. What's the problem? How did you identify it? What did you do? And then what impact did it have that we're required now really in our research setting whenever we try and go for funding. As a very last thing, you're nearly there. One of the projects I'm working on at the moment is with the University of Tasmania, and we're looking at axial spondyloarthritis or ankylosing spondylitis as a subgroup of that. And they're a fascinating group when we look at their changes on MRI. And we're with Jim Elliott at University of Sydney. We're in a project where we're trying to train artificial intelligence to measure these muscles for us. So instead of us sitting there and manually segmenting these muscles, that we can actually teach the AI to do that for us. So this was just a couple of weeks ago, and it was nice and chilly in Tasmania. And we were down actually pulling out all these MRIs. And our next step will be to see if we can use the AI to do the automatic segmentation of the muscles. Here are some of the images, just to give you a quick look. Early ankylosing spondylitis. Here's some multifidus. See, all the other muscles look pretty normal. But here's this fatty infiltration, again, right next to the bone. And when you think of ankylosing spondylitis and the enthesis organ, it makes sense that that's why it occurs in these patients. And again, it's interesting pattern, always next to the bone, and very distinct in these patients. So it'll be a great study for us to train the CNN to actually measure. But by the late stage of the disease, you can see the muscles, the lumbar rectus spinae and the multifidus, they're almost completely fibrotic fatty infiltration of the muscles. There's very little viable contractile muscle left. So we have all that clinical data as well. So I think it'll be a really interesting group to study. So there's some of the other members of the research team, the MARTA crew, and some of the people I work with at Griffith and U.K, and some of the other institutions and funding agencies that have helped with all of these studies. So that was a real snapshot of across the board for you. So I'll stop sharing.
Thank you, Julie. That was absolutely amazing. I really enjoyed that. And it was so interesting to hear about all the different studies that you've done with terrestrial populations and elite athletes as well as astronauts. Wow. I'm just thrilled that you came along today to share all that with us. So thank you.
You're most welcome.
Okay, now to all of you out there with your cameras turned off, if you would like to ask a question, then please turn your camera on, unmute and go ahead.
Hi, firstly, thank you for the talk. But I had a question about, you talked about how getting back to regular activity and sort of that early rehab was like really important for preventing recurrence of injury. I was wondering, is there sort of something you're waiting for? Because obviously after an injury, you kind of want to try and heal it a bit, I guess, before you start using the muscle again. So is there like a specific thing you're waiting for before you get back onto that rehab?
Yeah, I suppose they're really interesting with acute low back pain. Like back in the day, 20 years ago, remember they used to prescribe bed rest for back pain. So they don't do that anymore long term, but certainly in that first 24, 48 hours, if you've got an acute list and you can't stand up, you need to rest. But things like activating those muscles, you can do it very gently while you're lying down. It mightn't be your main priority if you're lying in bed in agony, but the rehab probably starts really early on with re-education. And that approach with the, you might have seen with the bed rest patient, with the ultrasound, we can actually teach people to activate their muscles quite gently. It's really important that it is short of pain because you don't want to hurt people when they're in acute pain, but they can start lying down. They don't have to be, up and about. That functional retraining comes a lot later. The education part of it is, back pain is fearful. If you have a broken arm, you don't like it, but you're not scared of it. But back pain people are terrified of. So a lot of the physio and ED work for back pain, apart from pain relief, is education. Is that this will get better, and you want to avoid the things that really aggravate it, and warning people that if they're put on pain relief, that you don't really want to be constipated with an acute back. We want you to move, but move in a pain-free way. Get up and walk around or lie down. Try and avoid sitting. One of the things that happens with acute low back pain is that real fight or flight response. So you'll see these poor back pain patients, their shoulders around their ears and they're almost panting because they're so stressed. So all that early work for the muscle system is trying to avoid people really getting overactive muscles. So, I know it hurts, but I want you to try and relax your shoulders. I want you to try and use your diaphragm to breathe. So that really early on stuff, you're right, you're not making them exercise hard, but you do want to try and educate them and avoid problems that we know can occur.
Awesome. Thank you so much.
Hi, I really enjoyed your talk. I just thought it was really interesting.
Thank you.
I had a quick question about, I know you're talking about the language that you use with like using reconditioning versus rehabilitation. Are there any other sort of language changes that you see really helpful in patients that are sort of, for example, with athletes, the sort of reconditioning versus rehabilitation? Have you seen any other sort of language changes that have made a really big difference in their perception of their recovery?
Yeah,
or with astronauts too?
Language is really important. I think the astronauts are a really strong group in that they really don't want to be seen as sick. They don't really want to be seen. They definitely don't want to be seen as patients. So that's why I think they like reconditioning. And they're right, actually. They've just been exposed to microgravity. They haven't had an illness. So it's reconditioning is good. The other really big language one you find for your athletes, as well as your back pain patients, actually, I think the biggest area I've seen it is imaging, is that the language you use around imaging, you have to be so careful. So in elite sport now, they often are minimizing the use of imaging because as humans, we see something on an image and they say, oh, look at that. You've got the back of an 80-year-old. And the negative effects on the poor patient is just irreparable. So I think now they're trying to actually encourage people to say, look, there's all these changes on imaging, but they don't correlate with pain. So you can have really horrible imaging and you can be pain-free and vice versa. And change is normal. So you show some of my age an image, and I'm sure I've got lots of wear and tear on my images, but you don't say, oh my God, look at that. that's had it. You got the back of an 80-year-old that, oh, look, there's changes on here. You can see from your report, or you've probably seen on your report, you've got these changes, but changes are age-related and normal and don't correlate with pain. So I think that's the other area, if you want to think about an area with language that is super important, is the language we use around imaging, because it is a fearful condition. And once people are scared and they say, oh, your discs had it, and I think, gosh, this thing could blow at any time, I'd better be really careful, I'm going to end up in a wheelchair. It's, oh no, look, the discs are really strong, robust structure, and look, I probably have discs that look like that. We've just got to get on and get your muscles we can change. Let's go down and make them as good as we can to protect your back. That kind of language, I think.
Any other questions? Otherwise, I'm going to ask one.
Oh no. Here comes a doozy.
Well, hopefully not. When I was putting the course together, I watched a lot of presentations by a whole range of people here and abroad. And one of the presentations on musculoskeletal health mentioned that patients who have conditions like chronic fatigue syndrome, that they were seeing that loss of lordosis in a similar way to what you see with bed rest and with what happens to astronauts with that kind of flexed posture. And I was just curious if you have any insights into that particular observation. Thank you.
I don't really with chronic fatigue, but certainly a group of researchers from NASA showed that the changes in the lordosis, so the flattening of the lordosis in astronauts, was correlated with the changes in the multifidus. So we do have this idea that it's not just, microgravity and, the discs imbibing and the changing of the shape of the spine. There is this direct relationship between muscles and muscle control and the lordosis. So I think that's probably important for lots of conditions, actually, because it kind of makes sense. If it's the muscle that controls the lordosis and it's not working properly, the lordosis changes. Now, we know from studies where they use fine wire and look at people in different positions, if you change your position, it changes the muscle recruitment. So I think you've got this vicious spiral thing happening where if you can't control your position, your muscles don't work. If your muscles don't work, you control your position even less. So I don't know if that's the answer in chronic fatigue syndrome, but they're intimately linked, as are, bone density and muscles. And we kind of often separate things out and think of muscles and exercise and bones. And of course we never should, because it's the muscles pulling on the bone that keep it healthy as well. And it's a living tissue. So I don't know if we understand a lot in that area, except that they're intimately linked, and we probably, could learn a lot more.
Oh, yeah, absolutely. That makes a great deal of sense. And I guess with people feeling tired all the time and kind of they tend to slouch, and so they're not recruiting the muscles that they normally would. So that was a really great insight. Thank you for that. Okay, any more questions? No? Well, in that case, I would like to say again a very, very sincere thank you, Julie, for coming along today and giving us such a wonderful presentation and answering those questions for us. It's been a real privilege, and we really, really appreciate it. And if we could please show our thanks to Julie.
Thank you. You're most welcome, and good luck with the rest of your course. It sounds like a fantastic course. So good luck.